Thank you. I thanks organizer for giving me this opportunity to present this interesting topic of local therapy in the form of SABR for RCC. So the name of the study, so this is a study done by Trans-Tasman Radiation Oncology Group, FASTRACK II, Focal Ablative Stereotactic Radiotherapy for cancers of the kidney. These slides are taken from Dr. Shankar Siva, who is the principal investigator for this study, and it was presented in ASTRO 2023, San Diego. So SABR, stereotactic ablative body radiotherapy, is an alternative, and it has all the advantages that it avoids general anesthesia, it is suitable for perihiral tumors, it is used in larger tumors, and it is non-invasive. Thermal ablation cannot be done for perihiral tumors and for larger tumors, and it is an invasive procedure. So the objective of this study is to investigate the efficacy of SABR in the first multi-center phase 2 trial of non-surgical therapy for primary RCC. The target population was the patients who were not suited to active surveillance or surgery, or they failed. The primary outcome was to evaluate local control after SABR, assuming a 1-year local control of 90%, and the null hypothesis of 80% considered less than equal or less than 80% considered not worthy of proceeding to a future randomized control trial. So it was done from a collaboration of a Trans-Tasman Radiation Oncology Group and Australia and New Zealand urogenital and prostate cancer trial group. One center in the Netherlands was involved, and 7 centers in Australia were involved in this study. 70 patients recruited between July 2016 and to February 2020 were evaluated in this study. The key eligibility criteria and patient characteristics: biopsy confirmed RCC with a single lesion in kidney, medically inoperable or high risk for surgery, multidisciplinary decision that active treatment is warranted, eGFR greater than 30 mL per minute, tumor not abutting bowel, tumor maximum size not larger than 10 centimeter. Median age was 77 years, BMI 32 kg per meter square, Charlson comorbidity index 7. This is a distribution of a patient in the form of a T stage. So 34% patients T1A stage, T1B 39 patients, 6 patients of T2A, and 1 patient of a T3A disease. The important baseline characteristics: so the tumor maximum dimension of a tumor. So there were 2 dose regimens which were followed for SABR: 26 Gray in single fraction and 42 Gray in 3 fractions. So the maximal tumor dimension in 26 Gray arm was 3.3 centimeter. That is a median, the average maximal tumor size. And in the 42 Gray arm, it was 5.3 centimeter. The median maximal tumor dimension for overall 73 patients was 4.6 centimeter. And the renal complexity score was 8 for all patients combined together. So this is the schedule of assessment for the period of 5 years. So CT, thorax, and abdomen to be done at baseline. The frequency is mentioned for first, second, third, fifth, up to 5th year and 5th year onwards. And similarly for eGFR and GFR and whole body scan. So moving ahead with the clinical outcomes at a median follow-up of 43 months. So these are the excellent outcomes demonstrated by this study for local therapy of renal tumors. At a median follow-up of 43 months, 100% local control rate, freedom from distant failure 99%, cancer-specific survival 100%, and kidney function loss minus 14.6 mL per minute. 1 patient underwent dialysis. So this is an excellent tumor control for primary RCC, local RCC. So the discussion is the TROG 15.03 FASTRACK II is the first multi-center trial of a definitive non-surgical therapy for primary RCC. Median tumor size of 4.6 centimeter is larger in this study than that of EORTC 3 centimeter and Brazilian 3.5 centimeter randomized trials of radical nephrectomy versus partial nephrectomy. Observed excellent efficacy is likely attributable to potent biological dose and rigorous quality control. So SABR for kidney is not a routine procedure as of now. This study has an excellent quality control mechanism inbuilt as a part of the study, and that's why the investigators could get such excellent results. Despite larger median size, 4.6 centimeter, than RCTs of surgery, renal function loss is comparable to partial nephrectomy. No grade 4 or grade 5 toxicity, but grade 3 SABR toxicity in 7 patients, that is 10%. It was mainly in the form of a transient pain in 3% or nausea and vomiting in 4% patients. Prophylactic antiemetics or steroids were not mandated in this trial, but should be considered. Tumors were larger and more complex than could be reasonably treated with thermal ablation. So, SABR for kidney is a new standard option for primary kidney cancer not suited to surgery. And these outcomes support the design of a future randomized controlled trial of SABR versus surgery for primary RCC. Thank you.